Thank you, Chair, and good morning, everybody. I just wanted, before I move on to my actual questions, I just wanted to pick up on when there was the question about UK cities. I was kind of expecting that there might be some discussion about climate risk as something that cities are looking at and thinking about in relation to health, and things like, you know, the kind of temperatures we saw this summer, ambulance call-outs going up, and just, you know, there are huge risks if you have very extreme heat in summer, of people being in their flats, overheating, and, you know, they're not out and about. You can't see that their health is struggling. So I was just wondering, I'd asked a question actually to the Mayor recently, based on the Lancet countdown from 2022 about there being insufficient climate change adaptation efforts have left health systems vulnerable to climate change related hazards. And the Mayor's answer was that the recently established London Climate and Health Network will be working with the GLA Group Public Health Unit to bring together leaders from across the health and care system to focus on the challenges of climate and public health, and to establish a set of priority actions for increased health system resilience. Now, I'm just wanting to know where that sits in the structure. Does that sit with you, Vicky, or does it sit with you, Jazz, or does it sit with both of you? And do you have a timescale for bringing forward your priority actions?
Thank you. So the evidence base around climate adaptations and mitigations has been an important part. It's referenced in the health and equality strategy. There's been lots of good work that's happened in the GLA, for example, the work on care homes, and adaptations that are required there, cool spaces, water fountains, etc. What we've done recently in recognition of the evidence base, the Lancet countdown, etc., is look at from a public health system perspective in London, where the GLA is just one player in that. So that is, yes, myself, my team, we now have a lead consultant that started, Emma O'Connell, and resilience will sit in her portfolio. She'll hold the relationship with the environment team, etc., around this, but with other parts of the system. So with OHID, with Association of Directors of Public Health, with the NHS, starting small, looking at bringing that evidence base about climate and health together for London. And we're working with the Institute of Health Equity, who are pulling together an evidence review for us, supported by a data pack about climate and health. That's one of the sequence of products they're going to be working up. But that group is slightly internal, looking at the moment around the bits of the public health system in London coming together, looking at how will we best support the various parts of the system, including the health and care system, on the adaptations that may be required as we go forward to support climate and health.
Do you have a timescale for when you expect to have a kind of set of priority actions?
So the Marmot review and that product we're looking at being published in the next 6 months, and that's a kind of independent, semi-independent look at that evidence base about climate and health inequalities. In terms of this network's development, I'm more than happy to come back to the committee. It's not, you know, we are working with the other parts of the public health system. I'd be reluctant to say there is a deadline for a particular product because we're not at that stage yet. It's been going 4 months now, 5 months. So there will be, with the Institute of Health Equity, a product focused on health inequalities, thinking forward to the health and equality strategy in the London plan. But in terms of bringing the public health system together to support other parts of the system, that's the element that we're still working through as a sort of network, trying to get the commitments from the different parties.
Thank you. That's reassuring to hear that much detail.
Okay, can I just add a quick addition? So we discussed at the London Health Board a while back air quality and climate change, and very much from the GLA, raising this as a significant issue. So the NHS now have their own green plan. They've got a clinical lead, Dr. Joe Savage, to deliver kind of a greener London from the NHS perspective. And so therefore each trust now, each hospital has got its own green plan to reduce emissions, reduce increase in temperature, address issues regarding green space. So therefore, I'm quite pleased the fact that NHS has kind of risen to the challenge that people like yourself and colleagues have raised. So therefore, it is now proper collaboration, and it isn't just the GLA, doing it on its own. And I think the wider system now recognises the threats of climate change. We used to think of always the threat of the cold winter. Now it is the threat of the very, very hot summer. Equally, excess deaths occurring in both scenarios.
Thank you. So, my next question is just about trying to understand a bit more about why the public health unit is separate from, and I'm going to have to double check what the name of it is, the Health, Children and Young Londoners unit. Sort of why those two have specifically have been separated out.
Thank you. Part of the purpose of establishing, I'll start with the role of the Health, Children and Young Londoners unit is very much kind of within the GLA and focused within the work of what we are doing as an organisation with our partners. The purpose of establishing the new public health unit was about having leadership level capability and competency in public health to work with and through the wider GLA group, so TfL, MOPAC and the other parts of the GLA group, so that they could play their part in being able to deliver their health impacts potentially. The leadership of that needed to be something that felt synonymous with the way in which local authorities work, and as Vicky's described, it's not the same as, but it's aligned with the role of a director of public health at a local authority. And that the gravitas, I think, that a director of public health brings with those skills and capabilities, as well as the essential skills that trained public health consultants bring, is vitally important. I think also going back to the concept of the statutory advisor to the mayor for health, for health, the legislation. So the GLA Act directs the Secretary of State for Health to provide the Mayor of London with a statutory advisor, and the provision in the Act also includes a deputy. And the Act talks explicitly about that statutory advice needing to be provided across the entirety of the Mayor's remit, so including the wider GLA group. And that's a function that needed to be designed and specifically designed so that it was advising everybody, including the Assembly, with the level of expertise and independent expertise, and partial only to the values of a public health community, so impartial in all other ways, and being able to kind of provide that there. Clearly, a group that's appointed by the Mayor's office to provide specific policy kind of support into the Mayor's, delivering the Mayor's specific priorities around health and well-being needs a different function, which is the reason why they needed to be quite separate.
Okay, so basically Vicky's unit is kind of looking to the public health system and that structure and engaging with that formal public health piece, and your unit is more about delivering the Mayor's policies around public health.
Around health and well-being.
Health and well-being.
Yeah, so included in that would be how we're supporting, working alongside and collaborating with the NHS on some common areas of programmes of work. The work that we might be doing with directly supporting local government so that they are able to take about kind of more, so for example the delivery of some of our programmes are very much hand in glove with health service delivery. That is not public health necessarily, although it's, you know, in that wider scheme. The public health concept being much more about taking upstream the interventions that are really going to have an impact at population level.
Then how do you work together to avoid duplication? Sort of how does that work?
So we paid a lot of attention to the design, a lot of staff engagement and involvement in the design of the units and what it meant. The design of the public health unit coincided with some work that Jazz was doing to restructure that team. So it was kind of well thought through, I guess, in essence, and we took our time in doing it. The health inequalities health inequality strategy is the cornerstone of what we do. That's a statutory duty. It is a very good, arguable, a very good framework, very evidence-based. So that's the kind of cornerstone of what we're doing, and that applies to the group as well as anything else. In practical terms, our units meet regularly together, all of them, and that's about adding value not just in health, but children and young Londoners as well. So we have joint unit meetings, we have occasional joint management meetings as well. There are key elements like learning and development of staff that we're taking forward together. Our approach to EDI would be another example that we're taking forward together, and staff wellbeing activity, because we'd recognise that for staff at different levels in our unit, some of the less formal interaction they have is quite inspirational, and that works both ways. So there are people in my unit that want to understand much more about programme delivery, for example. Colleagues in Jazz's team want to understand more about, whatever evidence-based practice, etc. So there are lots of touch points where the teams come together, but we do have, separate budgets, separate delegations, which I think is important in teasing out the accountability we have for the shared service agreement with the GLA group organisations. What are we delivering for them and with them, and will also help us navigate kind of potential kind of conflicts of interest if they were to arise.
So just taking an example of something that's very much in the news at the moment, the case of Awab Ishaq, who died from breathing mould in a cold, damp flat. Where, that's something that and it's a shame Onka's not here because he was on the Environment Committee when we did our report, Keeping Out the Chill, which actually has some very good solutions on damp and mould and actually addressing the housing stock to make these buildings that are prone to condensation and mould fit to live in. But when something like that comes up, we know, any of us who are counsellors will have casework going back years of people being told to put a lid on their saucepan, being told not to have long showers, being told not to hang their washing indoors to dry, when actually the problem of the mould and condensation, which is impacting their health, is to do with the structure of the building that they're living in. Where does a conversation about an issue like that sit? Does it sit with children, young people? And what conversations have you had conversations about that case?
Thank you. So, yes, we've had conversations about that case. So the case in and of itself is initial heads up. We would expect probably a prevention of future deaths review in the same way as that we had with Ella Kissy Deborah and the case of air quality, and then that translating into some specific recommendations about actions that different parties need to take. We haven't had that yet. In terms of what has kicked in, yes, it's a child in this case whose health was impacted. So absolutely, we would work with the Health, Children and Young Londoners unit. We're also docking into the Directors of Public Health, who are wanting to mobilise advice, as you can imagine, with their housing providers, with their housing teams. What advice can be mobilised immediately that can support local strategies, whether that be through housing associations, council accommodation, private rented sector. So my team, it would work as part of that public health network. We have a public health leadership group. We meet every 6 weeks. So we can mobilise very, very quickly around these things to make sure that the latest available evidence is available. America, for example, has done quite a lot of this kind of with post-flooding risk. We're able to link into UXA, UK Health Security Agency, around evidence that they have, but also what plans they might have in train, existing work that might be in train, as well as the housing team here. And critically for us, it's one thing having a conversation as a public health community, but the value of this is helping the GLA group play its part in full. And that would be the Children, Health and Young Donors unit and the relations they have through the Healthy Schools programme, Healthy Early Years programme, etc., if the evidence points to that being an opportunity, but also our housing team. Now, my team, we are new, so we don't necessarily understand yet every single opportunity, every single lever, and there are limits to what the GLA group can do in any one of these circumstances. So the kind of immediate assessment is understanding what evidence is there, what are the roles and responsibilities, who's wanting to take action, mobilising resources quickly to get the evidence available, and that's happened. So there was a circulation early this week, and my team played into that, working with AXA colleagues and council colleagues about mould and health. And it would build, for example, on the work the Assembly did, as well as AXA, coordinating that, bringing it together, getting it out to the front line quickly, and then my team asking the questions, okay, well, what does that mean for the GLA group? Yeah, and in this case, very much with our housing team colleagues, Health, Children and Young Londoners unit in this case. Yeah, but also preparing as a strategic authority for what may come down the line in terms of a prevention of future deaths report, recommendations, yeah, and then looking at how is there any pre-work we can do, how might we mobilise as and when that happened.
I just add, so just to add, I suppose, on a very practical level, I suppose, when something like that is, there's public attention on something like that, the practical thing that we would do is Vicky and I would simply have a conversation about it first of all and work out the plan. But I mean, this is a very clear case of this needs the public health unit's kind of consideration. They would then do that work. The kind of stuff that my unit would be doing would be thinking about, well, what does that mean for, what do our health and care partners who are interested in child health think about this? Who are the people that are going to, who are the kind of child health voices out there that we're working with, that we're our stakeholders and partners? What's our collective view? What is the position that we would want to be seeing taken, whilst at the same time there's a very practical set of kind of what the public health impact here and what those kind of, for example, kind of the reviews and the impact of the work that we would do. But we work so hand in glove. This is the kind of thing that we can very quickly work through and be quite clear as to what how we need to operate between our two units.
Yeah, I'm done. So thank you. But I will send you both the Keeping Out the Chill report from February 2019, because there is a project at Thamesmead where they have retrofitted active ventilation in flats, particularly focused on overcrowded flats where the condensation and mould was worse, and it made those flats in a building that was prone to mould, it stopped the mould from forming. So there are some solutions out there, but it's not a well understood problem, and I think our report was quite helpful.